taking is an understatement. It has the potential to transform healthcare for our veterans and to finally realize the goal of having one seamless lifetime health record for our service members as they transition from the military to veteran status. However, this effort also has the potential to fail. VA, unfortunately, does not have a great track record when it comes to implementing information technology. Decades of oversight by the Government Accountability Office and the Inspector General have documented a troubled history of failed IT projects, including several failed attempts at a modernized electronic health record. At the subcommittee's hearing on April, I asked the IG and GAO what it would take for the VA to be successful, and it really comes down to two things: management and leadership. VA's inability to manage IT programs and have accountable leadership has plagued many of its recent IT efforts, and it threatens EHRM. The lack of an accountable joint governance structure between the VA and DoD also threatens the success of this project. After months of requesting information, we have yet to receive anything of substance about a proposal to address the non-functioning interagency program office. What we have heard is not promising. It sounds like it is the status quo with a new name. Congress first mandated an interoperable health record in 2008, and it is beyond time for the Department of Defense and the VA to have a fully functioning health record systems that can talk to one another and support seamless health care. Seamless healthcare is what this effort really is about, and it is more than any one system, contractor, or agency. It's not about the technology, but about the human interaction with the technology. The system we are spending at least $21 billion on at both the departments is merely a tool that will allow clinicians and others to provide the best possible healthcare experience to those that served our country. We owe them nothing less. Because this mission is so important and because taxpayers have made and will make a significant investment in it, this subcommittee owes it to veterans we serve to ask difficult questions and demand full answers at every step of this project. We need leadership to be transparent about the challenges and accountable for their decisions. Additionally, we are aware that there is some rhetoric out there about speeding up the EHRM implementation. But I want to be very clear that I do not share the opinion that we should move faster for the sake of moving faster. We should instead spend the time getting it right at the initial sites in the Pacific Northwest before we move on to other implementation stages. This spring, I spent some time at the Madigan Army Medical Center and heard from frontline staff about the problems that were experienced when things like testing and training were rushed. Further, I visited the Seattle VA and saw the very serious infrastructure issues there that threaten or delay or to derail the implementation. There are many lessons to be learned from the DoD rollout of MHS Genesis, including obvious pitfalls that need to be avoided by the VA. This subcommittee will be conducting oversight of all of these things. For the first time, and thank you very much, we have the major contractors involved in both the VA and DoD efforts before us. I'm pleased that we can make this happen because I believe it is a real opportunity to examine these programs from every perspective and ensure their successful implementation. Cerner, Leidos, and Booz Allen Hamilton are part of the day-to-day efforts of the EHRM at the DoD and VA, and they know intimately the lessons learned, and they are helping prepare for the potential problems ahead. I know we all want the MHS Genesis and EHRM to succeed for our service members, veterans, their families, and taxpayers, and I hope we use this opportunity to figure out how we get these IT projects right. I thank all of the witnesses for being here, and I look forward to their testimony. I'd now like to recognize my colleague, Ranking Member Banks, for 5 minutes to deliver any opening remarks that he may have.
Thank you, Madam Chair. I am pleased to be back here with you to discuss VA's Electronic Health Record Modernization, EHRM, program. It has been just over 1 year since VA awarded its primary EHRM contract to Cerner. I continue to believe this program is so large and important, not just for our veterans, but also for American healthcare, that status reports should happen in public. My goal today is to make sure that one is provided. We are still in the middle of the beginning, but vague conceptual notions are becoming pressing questions and decisions with real impacts on people's lives. VA's first site, the Mann Grand Staff Medical Center in Spokane, is scheduled to go live with the Cerner EHR less than 1 year from now. There is an even earlier deadline right around the corner. The councils of employees who are test driving the Cerner EHR and designing the new workflows are scheduled to finish their meetings in September. These 18 councils are each at very different points in their respective processes. Some are still near the beginning, while others are somewhat ahead of expectations. September through March 2020 will be an intensely active period, while milestone after milestone must be completed in quick succession. The risk of delay is very real. Some of my colleagues who do not sit on this committee have expressed frustration with the length of the site-by-site implementation. No delay is ever welcome, but taking a few extra months to get it right is eminently preferable and responsible compared to cutting corners or rushing a half-baked system into use in order to avoid criticism. The reality is the performance of this Cerner EHR and VA's initial operating capability sites will determine the course of the rest of the program, including, in all likelihood, whether it continues at all. Much has changed since our last EHRM hearing. VA and Cerner have agreed to an ambitious data migration plan that hinges on repurposing Cerner's Health E intent population health software. I have some questions about how this will actually work. VA has demonstrated some impressive use cases in connecting to external apps through the API gateway. The most high-profile success is enabling veterans to access their records through Apple Health. This sort of capability would have cost the department hundreds of millions of dollars to develop in the past, but the partnership was accomplished in about a year for a tiny fraction of that. I suspect that there may be some more big app partnerships in the near future. On the other hand, some things haven't really changed at all. Interoperability with the community providers is still the elephant in the room. Cerner has some strong interoperability offerings inside and outside of the EHR, but millions of veterans already get care in the community, and no matter how long or short the site-by-site implementation may be, they rightfully expect their records to follow them. The Mission Act, which is only 2 days away, will streamline community care administratively. We need a comparable solution to deploy the interoperability technology in months, not years, and nationwide, not place by place. We can do better than repackaged email or fax. Relatedly, beyond some platitudes, no innovation strategy has been articulated. The Cerner contract contains an innovation line item, but it is the smallest line item in the contract, and it has not yet been touched. Cerner has a multi-hundred-million-dollar research and development budget, and VA will make up about a quarter of the company's revenue in a few years. The government negotiated extraordinary data rights in its contract, but I am still eager to hear how all of this investment is supposed to translate into some specific advancement to solve VA's specific problems. I understand the desire to get the basic EHR in place before turning to innovation. That reflects caution and modesty, which are both admirable. But it is very important to me, and I hope to the rest of this committee, that innovation does not get neglected. Finally, in addition to an extraordinary number of decisions to be made, there are bound to be many unforeseen issues that will arise that will test the management structures that VA, DoD, and these companies have in place. I wish I could say I have more confidence in those management structures. VA and DoD opted for a single common system, but after 9 months of haggling and jockeying for power, a suitable single common management structure has still not yet emerged. Frustratingly, the departments have refused to share virtually any information with Congress. In the absence of a comprehensive solution, The technical personnel in EHRM and MHS Genesis have put together some effective coordination mechanisms. However, that is unlikely to be sufficient to address clinical questions or resolve programmatic disputes. I appreciate our witnesses from Cerner, Leidos, and Booz Allen Hamilton being here to speak to us directly about these issues. Next week, we will hear from the VA and DoD witnesses about your work. So I am sure we will do I'm sure we will do many more times. But this is your opportunity here to give us your perspectives, and I appreciate that very much. With that, Madam Chair, I yield back.
Thank you, Mr. Banks. I'd now like to introduce the witnesses we have before the subcommittee today. Travis Dalton is the president of Cerner Government Services, which is leading the health record modernization effort at the VA, and is a subcontractor on the DoD effort. Mr. Dalton is accompanied by David Waltman, Vice President for Strategy and Technology, and Julie Stoner, Director and Client Accountable Executive. John Scholl is the president of Leidos Health Group, which is the lead integrator for the DoD implementation of MHS Genesis. Leidos also has a role in the VA effort as a subcontractor. And finally, Mr. Richard Crow is an executive vice president at Booz Allen Hamilton, which has a contract to support the EHRM program office. We will now hear the prepared statements from our panel members. Your written statements in full will be included in the hearing record. Without objection, Mr. Dalton, you are recognized for 5 minutes.
Thank you, Chairwoman Lee, Ranking Member Banks, and distinguished members of the committee. My name is Travis Dalton. I'm the president of Cerner Government Services. Appearing with me are David Waltman and Julie Stoner from Cerner. We thank you for the opportunity to be here today. And for your continued support of the Department of Veterans Affairs Electronic Health Record Modernization Program. Just over a year ago, VA partnered with Cerner to proactively transform care for veterans and help them lead longer and healthier lives. We remain honored and humbled to be a part of this mission, and we have assembled a world-class partnership to deliver it. EHRM is not just about technology, it's about transformation at scale. We realize the size and complexity of the VA. This won't be easy, but it is achievable, and we are making progress. This program will ensure a lifetime of seamless care for veterans and service members across the Department of Defense, VA, and community providers. VA has a long history of innovation and excellent care for those who have served all of us. We are building on that foundation together. This project will give providers the right tools and data at the right time to make the right decision. With the HRM, service members and veterans will no longer have to carry stacks of paper. Providers will have access to the veterans record wherever they deliver care. Using advanced analytics and decision support, we will be able to identify, diagnose, and manage chronic conditions, combat suicide, opioid, and substance abuse through interoperability and workflow tools, operationally move from 130 disparate systems to one open, modern, integrated system that's easier and more efficient to update and maintain. It won't happen overnight, but we can and will achieve these goals together. This undertaking is immense. It carries risks, and we don't take the challenges lightly. We must deploy to over 1,700 sites, train over 300,000 VA employees, collaborate with DoD, interoperate with the community, aggregate decades of clinical data, and update technology. The only way to get there is for us to work together, VA, DoD, all of you, our partners here today, VSOs, and other stakeholders. We're on the right track. We have confidence in Mr. John Wyndham and his leadership of this effort at the VA. That has been imperative to our progress. Some examples of that progress include we've established 18 councils made up of VA care providers nationwide, Cerner experts, industry leaders, and DoD. The councils have completed 5 of 8 national workshops. They're making decisions, setting standards, and bringing best practices to the table. We created an advanced learning academy, along with Booz Allen, we have a robust team in the Pacific Northwest. We've completed 18 of 19 road shows to engage providers, and we migrated 23 million veterans' health records into the Cerner data center. VA and DoD health data are in the same system. We're impressed with the dedication, spirit, and passion of the providers we work with inside VA and DoD. We're humbled by the opportunity to be in VA medical centers and to interact with providers receiving and veterans receiving care. This is personal for many of you. I know it is for me. We can do this, but it will take all of us working closely together. On behalf of Cerner, we are honored to be a part of it. Thank you, and I look forward to the discussion today.
Thank you, Mr. Dalton. Mr. Scholl, you are now recognized for 5 minutes.
Thank you, Chairwoman Lee, Ranking Member Banks, and members of the subcommittee. Thank you for the opportunity to provide a contractor's perspective on modernizing the health records at the Department of Defense. My name is John Scholl. I'm a president of the Leidos Health Group. We're the prime contractor for the DoD Health Management System Modernization, also known as DHMSM. On a personal note, I graduated from the Naval Academy. I'm a former submarine officer who deployed to the Western Pacific. I have children and a spouse who have been treated in the military health system. I have a son who served in the 82nd Airborne in Afghanistan and depends on VA services for service-related injuries. So this mission of health records and interoperable solutions is very personal for me, as it is for many others on my team who have served or have family members who served. With me today is my senior team associated with this work. Debbie O'Pekin is a Senior Vice President for Federal Health. Doug Barton is the Chief Technology Officer for the Health Group and Chief Engineer of the DHMSM program. Dennis Nyheiser is the Senior Program Manager for DHMSM, and Rob Thomas, the Acting Deputy President for the Health Group. To best encourage teaming and sharing lessons within and across the DHMSM team, we created the Leidos Partnership for Defense Health, which consists of 4 core partners: Leidos, Cerner Corporation, Accenture, and Henry Schein One, as well as many other supporting businesses. Together, we are developing an integrated, modern, and secure health information system that includes an electronic health record system, a dental system, identity management capability, cybersecurity, and other supporting components. This integrated system is called MHS Genesis, and it will provide a solution for managing the health and readiness for the DoD, ultimately the VA and the U.S. Coast Guard. Although information sharing is possible today between the DoD and VA, it is limited by the fact that these organizations have operated systems that are mostly independent from one another, largely requiring view-only, and some patients still carry paper medical records as they move between organizations. We know this is a significant frustration to many, and appropriately, Congress has directed the agencies to fix this long-standing problem. MHS Genesis is ultimately incorporating VA essential requirements is the solution. I can assure you that from initial contract award until now, we have learned a lot, and we will continue to learn. I'm pleased to be with you today to share some of the insights we have gained. We work extremely closely with our DoD customer, and the partnership is committed to executing 3 equally important objectives. 1, deploying MHS Genesis on time and on schedule. 2, continually improving the implementation of MHS Genesis based on lessons that we learn. And 3, successfully modernizing the delivery of healthcare in the military health system. MHS Genesis is well underway to transforming how healthcare is delivered to nearly 10 million service members and their families. The solution consists of integrated commercial products designed to help efficiently manage the health of our service members, veterans, retirees, and their families. MHS Genesis allows clinicians and patients to access needed health records and, importantly, ensures our service members receive the same standard of care no matter where they are in the world. The Leidos Partnership for Defense Health went live at the initial operating capability sites in 2017. This included 4 military treatment facilities and more than 20 ancillary clinics. It allowed the team to pilot MHS Genesis, to learn, and to incorporate feedback into future implementations. This learning loop will continue as more facilities go live. We are counting on the process of implementing and learning in order to accelerate and provide the best solution possible in the best possible ways. These initial sites continue to use MHS Genesis today to safely deliver care to patients, completing more than 100,000 patient encounters every month. In our opinion, the intended purpose of the go-live at the initial sites was achieved. which was to provide an outstanding health information system and to identify areas of improvement and set the course for corrections prior to broader deployment. Here's a quick overview of three things that insights that we gained from implementation. One, we refined our approach to training. The curriculum is now better aligned to clinical processes, also called workflows, and we are using improved team-based, role-based, and just-in-time-based training methods. Two, the underlying IT backbone, the networks, the computers, the printers, the medical devices, must be mapped and tested to support the new system. The implementation at our initial pilot sites identified the critical importance of validating and revalidating that the necessary infrastructure is in fact ready. And three, implementing complex systems is fundamentally a people business. Changing clinical processes is hard. The commercial technologies that comprise the MHS Genesis system are operational in health facilities around the world. The most challenging work ahead is not only the engineering to ensure that the underlying components continue to work in a secure environment, but also work closely with a dedicated and amazing medical staff to best implement the MHS Genesis solution. In closing, Leidos and its partners are confident in our ability to implement the integrated electronic health record system, MHS Genesis, across the defense health community by the end of 2023. Our team is honored and committed to fulfilling this noble mission. Thank you, and I look forward to your questions.
Thank you, Mr. Scholl. Mr. Crow, you are now recognized for 5 minutes.
Good afternoon, Madam Chair Lee, Ranking Member Banks, and other members of the subcommittee. My name is Richard Crow. I'm an Executive Vice President at Booz Allen Hamilton and Client Service Officer for Booz Allen's Health Account. In that role, I lead a diverse portfolio of health service contracts, including IT and healthcare operations contracts. That portfolio includes our Electronics Health Record Modernization Program Management Office Support Contract at the Department of Veterans Affairs. Booz Allen has a strong, demonstrated commitment to serving our nation's veteran population. Booz Allen was founded by a veteran, and the company has continuously supported the Department of Veterans Affairs since 1952. Booz Allen takes great pride in our 65-year history of supporting veterans, which we do in multiple ways. Approximately 30% of our over 25,000 employees are military connected, meaning they are veterans in the National Guard or military spouses. And Booz Allen invests in helping our military connected employees thrive through career building, best-in-class benefits, formal programs for military spouse support, and support to the military and veteran communities through innovative and impactful nonprofit partnerships. We are committed to the Department of Veterans Affairs' mission to serve our nation's veterans. I am pleased to be here with you today to discuss Booz Allen's support in the role of the VA's Electronic Health Record Modernization Program. I'd like to begin today by discussing an overview of the role of a PMO support contractor in our work, who we support, and how we interact contractually with the other witnesses here today. The role of a PMO contract support. As the VA's PMO contractor, our role is to help position the VA for success in three main areas. First, we provide surge staffing, resources, and tools, as well as management, engineering, government expertise to augment the VA program office's own capabilities. Second, we help the government obtain specific skills and talent relevant to the EHR implementation for the necessary duration at the relevant stage of implementation process and in a time-bound manner. Third, we assist the implementing organizations by helping the respective workstream leaders break enormous projects into discrete, actionable, trackable, and measurable tasks. The VA's use of a PMO support contract is consistent with other commercial and governmental EHR implementations. Who we support. Our role as the PMO contract support, Booz Allen works at the direction and supervision of the OEHRM PMO under a time and materials contract. Our job is to respond to a range of VA taskings required for successful EHRM implementation. We play a supporting role to the PMO and do not have our own independent development scope, nor responsibility over specific EHRM development, deployment, and implementation tasks. Structurally, our team mirrors the VA PMO in that we are organized into workstream pillars, which we support at the direction of a VA lead. The primary work streams focus on assisting the Chief Medical Officer, Technology Integration Office, and Program Control. how we interact with other contractors. We do not have independent scope or responsibility for the EHRM implementation, nor do we direct Cerner. Our interaction with Cerner is at the direction and in support of VA. Thank you for the opportunity to testify before the subcommittee today. Booz Allen is proud of the support we are providing the VA, and we have great confidence in the VA's leadership of the EHRM PMO. I look forward to your questions.
Thank you. I will now recognize myself for 5 minutes of questioning. This is for both Mr. Dalton and Mr. Scholl. From a joint governance perspective, how are Leidos and Cerner working together to ensure that seamless care and interoperability are at the forefront of both of your respective implementations?
Thanks for the question. I'll apologize for my voice. My team is happy I can't talk, but it's not very helpful in this environment. You know, I think important thing around decision-making is that we're really working on focusing on decision-making at the lowest levels. We work closely together, obviously. We're on their team, they're on our team. We have a great working relationship. We know each other, we know our skill sets well. We have joint working sessions where we work closely together. Leidos is closely involved in the workshop process with us and the VA. We also have an environment management operating group that consists of VA, DoD, Cerner, and Leidos, which is working closely together on a regular basis. We have great relationships at the corporate and other levels. I think we work closely together in that capacity on the solution. We continue to do so. I don't know if Mr. Scholl, if you have anything to add to that.
Not much incremental, other than to emphasize that we are in operating rhythms where we're in meetings together, we review findings together, we work closely together from the lowest levels of our team to the highest levels of our organization, including recurring meetings at the most senior levels, myself and even our CEOs.
Mr. Dalton, Cerner's monthly project reports list delays in decision-making, sometimes carrying over from month to month. How much of that is a product of a lack of effective governance structure on behalf of the VA and DoD?
I think, look, I mean, it's hard. Clinical decision-making is not easy. We've got 18 councils. We're running a process. We're getting into, I mentioned transformation at scale. It's a big project. There's much to do. We're getting into difficult decisions around referral management, processes, workflow. I think all of those elements play into kind of where we're at on status. We're also making sure that we're getting national representation and local representation as part of this process. And tuning that into decision-making is not always an easy thing to do. But I think all of that has led into kind of where we're at today. We are behind in a few areas. We know what those areas are. We have eyes on target. We have the ability and the reporting to know where they are. We're having daily meetings, daily cadence. We're meeting with the VA and DoD. We have escalation paths to resolve those.
All right, thank you. This is for Mr. Scholl and Mr. Dalton. For some decisions, such as which access card would be used, the resolutions seem to take quite a long time to get to. Cerner developed a working group in an attempt to provide the DoD and VA with some viable options. Is that working group something that should exist as part of the joint governance structure, or was it a workaround due to the lack of an effective governance structure?
I think we had, from inception, always intended to have working groups at the Cerner Leidos level. So I wouldn't characterize it as a workaround to anything that DoD and VA, are striving for. Rather, we view it as our mutual responsibility to bring solutions to our respective customers. Travis?
Yeah, I'm going to let Mr. Waltman comment on that.
Okay.
Yes, ma'am. Thank you. I agree. I don't think that it represents a lack of or that progress was impeded specifically by a lack of joint governance. This was a very complex decision and a process that required a lot of input from within VA with various departments within VA and stakeholders, especially given the complexities of VAs contemplating moving to the U.S. Access Card from General Services Administration. So there were a lot of inside VA decisions that needed to be worked through, and I think that that happened relatively effectively between the two departments. There are also decisions that need to be made, such as enumerating users of the system with an EDIPI, which is the common identifier for the system, and the departments are still working through those. I think there are certainly opportunities for potential joint entity to help facilitate some of that decision-making. The EDIPI is a good example. Other memoranda of agreements, of understanding and agreements between the departments for how these systems will operate, particularly including privileges and things like that for access to the record, would be facilitated by joint decision-making.
All right. Thank you very much. I yield the remainder of my time, and now I'd like to recognize Mr. Watkins for 5 minutes.
Thank you, Madam Chair. Mr. Dalton, we hear the term interoperability a lot in these discussions about electronic medical health records. It's more than just sharing data between multiple systems. Can you expand on the concept, what it means for EHRM, and how it impacts the care of our veterans?
I'm happy to. Thank you for the question. Interoperability to us is more than just HIE to the community. It's many things, as you mentioned. So our goal and our focus is the right data at the right time and right place so that the provider can make a truly informed and best decision. There are a number of things that go into that. So we're bringing VA and DoD into a single instance or domain. We've got VISTA history that's coming into the environment. We've got device integration, real time. We've got reference lab and state PDMP data for opioid risk scoring. And we've also got open standards-based APIs. All of that is interoperability in our mind and allows the provider to have a true view of the longitudinal record and make an informed decision.
Mentioned opioid addiction. It and suicide are a problem among veterans. Not a day goes by when I don't think of a veteran I served with who committed suicide, and so it's a personal issue. How can the VA and DoD creating a single record based off of Cerner platform support us combating those efforts?
With opioid, we have the opportunity to integrate into the state prescription drug monitoring programs, so we can actually pull back data and have a risk score. So it allows us early identification, and it allows us to proactively look at those issues inside of the workflow. That's very different than a reactive situation or guessing. So that's one area. I think we also have the opportunity to innovate with the VA as it relates to data analytics, predictive modeling, early intervention related to suicide and PTSD. That's an area we want to focus on with them going forward.
Thank you, Mr. Dalton. Madam Chair, I yield my time.
Thank you. I now recognize Mr. Lamb for 5 minutes.
Thank you, Madam Chair. I want to thank all of you for being with us here today. I know it's not easy to come all this way. And I also know that we may or may not get a chance to be in front of you again for a while, just the way this process works out. So for the 3 Cerner witnesses in particular, I would just like to ask now, you know, it's June of 2019. We're all expecting a go live. I think it's October 2020, but at some point in 2020, you'll be really ramping up next year around this time. Is there anything you don't have from the government VA side, or you fear that you're not going to have between now and then that could impact the planned launch? Anything at all?
I think the primary element we've talked about really is around making quick decisions. So we need to continue to focus in that area. You know, it is hard, it is complex. I appreciate the commentary around getting it right. We also want to get it right. But I think just we do need that joint decision-making authority. We are operating effectively, I believe that, and we are getting things done, but there comes a point where you have to have that joint capability. We have a few examples. I'm happy to let the team describe what those are, sir, if you
Please, yeah, please go ahead.
Yes, thank you. Appreciate the question. Agree with Mr. Dalton in that there are a number of things that if we can ensure that they're facilitated between now and that time, will make things much more effective and much more likely to be the success that we all expect them to be for veterans and service members. So, for example, there are realities of working in a joint environment with the Department of Defense that we have to have a common cyber posture between the two environments. And there are decisions that the Department of Defense needs to make in authorizing, for example, assessment strategies for some of the technology, for example, container technology, or other decisions regarding connections between aspects of the system from VA to DoD. And although some of those decisions have been in process, we have not seen between the departments all of those at the speed that we would like to be able to ensure we maintain the expected schedule. So certainly joint decision, especially in that cyber area, is one area that I think is very important to us. And
Thank you. Have you, and just to be clear, have you made clear to the decision makers the impact that that could have on your schedule and the ability to launch this on time next year?
yes, sir, we absolutely have done that, and we continually monitor the status of these decisions and decision requests and brief their status and request facilitation and updates.
Okay, go ahead, Ms. Stoner.
Yes, thank you for the question. We've had a number of items, things that require either joint or VA decisions. We've been working closely with the VA between workshops, in addition to those surging during the workshops, to close out those decisions. And while we acknowledge that both departments have different missions, there are a number of things that have to be decided on jointly. For example, what do particular results appear to the clinician for? And so there's been a number of items that we're tracking to close out, bringing the two groups together. And as Mr. Dalton said, we're seeing progress there, but it's how fast and how scalable is that process and how consistent is it to be able to do on a regular basis.
Okay, so one example was basically data and cybersecurity and assessment of the technology that's being used. Were there any other concrete examples that you can give us today? Because we're going to have the DoD and VA decision makers in front of us regularly. It'd be helpful to be able to ask about these things.
So I think the biggest thing that we are looking for is a process by which we always make those decisions.
Okay.
So things like results viewing, that has to be consistent across the agencies. How the Department of Defense takes on new capabilities that become available because the VA has provided them. And as well, how do we continue to push both agencies to move on a commercial baseline, take advantage of those investments?
Okay, thank you. Madam Chair, I yield back.
Thank you. I now recognize Ranking Member Banks for 5 minutes.
Thank you, Madam Chair. A few months ago, Kaiser Health, News, and Fortune published a truly sobering piece of investigative reporting on the EHR industry. In case anyone missed it, I ask unanimous consent to enter the article, Death by 1,000 Clicks, into the record.
Without objection.
What I find most alarming is the issue of gag clauses, which are terms that some EHR companies put in their contracts threatening buyers with litigation if they speak publicly about the problems with the systems. Mr. Dalton, has Cerner ever imposed a gag clause, meaning any term or condition in any software license agreement or other contract that discourages any user from speaking publicly about any subject?
No, not that I'm aware of.
The negotiations between DoD and VA over leadership of the Joint Program Management Office, the firm, are probably one of the worst kept secrets in Washington. This has been going on since last fall, and the goalpost seems to have been lowered to putting interim leadership in place and standing up the office in phases through March 2020. This question is for everyone who wishes to answer. The two departments that have some technical integration in place, but what is going to happen to, the two departments have some technical integration in place, but what is going to happen to the EHRM and MHS Genesis if they don't integrate the other aspects? What is the impact on you, the contractors, trying to implement these projects? We can start on our right.
Well, I think we support the PMO on the VA side. And so in that we support the VA. Specific to your question, obviously strong governance across both these programs for common decisions is going to be critical. I think when you look at the proposed firm, this is a 10-year, as you said earlier, sir, it's the beginning, it's the middle innings of the beginning, and this is a 10-year process. So it's not necessarily inappropriate to take some time and pause to think how you want to have this structure come together from a governance standpoint. So I know the agencies are talking, and I'm not really in a position to comment on how they're going to ultimately come together.
Mr. Scholl?
Yeah, thank you. If I could play the question back to you and make sure that I'm answering precisely, Ranking Member Banks. What I thought you asked is, how much do we move beyond the pure technical integrations into other issues, and how important is that to us as the contractors? Yeah. Much has been said of decision-making, and I think as the DoD and VA get together and solve the decision-making processes to increase speed and efficacy, I think those are things that would be required. But we from the dim sum rollout, feel confident in where we are in the decision-making inside the DoD program, and look forward to working with Cerner and the departments as they implement new processes and procedures to make better decisions. So.
Mr. Dalton?
We aren't directly involved in the conversation with the firm. We provided some data points and some inputs and some thought. So I just can't comment on specifically where the agencies are at in relation to that. But it goes without saying, when you're in a single instance, single environment, there comes a point in time, if you can't agree and you can't make some decisions, it's hard to proceed forward. They need to maintain standards. There needs to be clinical decision-making. There needs to be timing. There needs to be joint milestone management. Upgrades will be done at the same time. So not only is it difficult to proceed, but you miss out on great opportunity actually to work together and get efficiencies and synergies that the two agencies can get with one another by doing so.
So to Leidos and Booz Allen, how can you implement Cerner as a single common instance if they don't have some sort of unified management structure, in your opinion?
Well, the contracts were sequenced in time. So the dim sum contract started before even the award of the Cerner contract. So I think there's going to be a process of the implementation of MHS Genesis, and as the VA requirements emerge, then we need to have this joint decision making and process resolving any conflicts so that we end up with a single instance and a single system.
Thank you. I now recognize Ms. Brownlee for 5 minutes.
Thank you, Madam Chair. So I wanted to go back and follow up on Mr. Lamb's questioning, and if I understood you correctly, that you said one of the issues in terms of meeting timelines and completion dates is, in essence, creating a system of joint decision-making, and my understanding of joint decision-making is DoD, VA, DoD and the VA and all of you, right? So let's just say hypothetically that system isn't created. I mean, do you have a timeline to get that? Does the VA understand the urgency? And if that isn't established, then it sounds to me like you're going to continue to fall behind scheduled due dates. Correct me if I'm wrong. Am I wrong? Yes, no?
Yeah, I think, as I commented earlier, we are making some decisions. We are proceeding forward, but yes.
No, I
yes,
understand
ma'am.
that. But what I'm understanding is there's some key decisions that,
Yes,
have to be made before you can make another big significant step in the process.
Yes, there are.
Right, so,
Yes, ma'am.
yeah, so I'm just, so if nothing is done, then sort of some key essential decisions aren't going to be made. Hopefully that won't be
That's
the
correct.
case. But if it is the case, is there a place in this process where we as Congress would understand that those decisions aren't being made and that we should anticipate further delays? Or is that simply something that you make the VA aware of, that we're not going to meet these deadlines because of X, Y, and Z, and that's as far as the information flow goes?
We have a process for risk management, obviously, that we work with both Booz Allen, Hamilton, and the VA. We're constantly evaluating risk. We're constantly evaluating our integrated master schedule and timeline. I believe we provide reporting on a regular basis to Congress and otherwise related to that. Our goal is for that to be readily transparent to all involved so that there's clear decision-making, clear understanding, and that we're able to proceed forward.
Thank you. And for Cerner, too, you indicated that, there are a few things that are behind schedule, and I think one of those is that you had indicated that that Cerner is saying that they are going to test every function throughout the build phase of the EHR. And actually, the VA is holding its last workshop where workflows are being developed and fine-tuned, and that's in September, October of 2019. So that leaves the VA and Cerner less than 6 months to complete the design and development, perform these tests on the completed system, correct any issues, and then design and deliver training to the end user. So this time frame, to me, seems ambitious at best and little room for error.
I think one major advantage that we have is that we're largely using some of the work that we've built together off of the DoD. So much of the workflow and the system will be the same. And so we're able to re-leverage some of the work that we've done collectively together on behalf of the VA. It is consistent with our commercial timelines for testing and training, so we feel confident, but we are able to leverage that baseline.
And is there, there are rumors that the VA is looking for another contractor to perform the testing. Do you know about that at all?
I do not know about that.
Okay. The last thing I wanted to ask is around data ownership. And the VA and the DoD's data have or will be moved into the Cerner's data center in Kansas City. What impact will the data being in a commercial data warehouse have on portability, access, and privacy? And then who is ultimately owns the data once it's moved to the Cerner's data center?
I'm going to pass that to Mr. Waltman.
Yes, ma'am. Thank you. So I think the answers to your questions are VA and veterans and the people whose data it is always own the data. The data is not owned by Cerner. And in terms of access and privacy, first of all, from a privacy standpoint, this is probably the most secure health information environment in the world at this point, with the requirements that have needed to be met for DoD. And I think I'm out of time.
You can have a few more seconds.
Okay, great. And in terms of access, I think that the access for folks to use that data, veterans themselves, service members themselves, and other companies who are interested in providing capabilities to help them will be greatly increased. We have APIs that provide access to that information as appropriately managed through our code program and so forth. And there will be a tremendous ability for vendors and people interested in helping veterans to provide capabilities that leverage that data being in one place.
Thank you. Thank you, Madam Chair.
Thank you. I'll now recognize myself for 5 minutes for questions, and I'd like to focus a little bit on the different contractor responsibilities, and I'll start with Mr. Crow. In your testimony, you note that Booz Allen's role is to support the program office of EHRM. The executive director for EHRM has stated something to the effect that when you think EHRM, think Cerner and Booz Allen. How is Booz Allen augmenting the staffing in the EHRM program office?
Thank you for the question. It's a good question. We provide, as I testified, surge support, variety of management, technical, engineering, clinical support. We bring folks with significant background in EHR implementation, a lot of experience in the federal space, and significant experience in the supporting the VA directly. Tests that are typical for a PMO contractor. We typically aggregate data, collect data, support field trips, support a variety of engineering reports, studies. We pull this together, and we present documentations and maintain documents and artifacts for the PMO that enable the government to make decisions and move forward in their role as the oversight and program management of the effort.
Thank you. The VA stressed the importance of these command action teams in the implementation. What is the role of the CAT, and when will they come into play?
So currently, Booz Allen has 30 people, approximately 30 people, a little bit over, in the Pacific Northwest. And the command action team, simply put, is an extension of the PMO. They make the PMO extensible to the local PAC Northwest facilities, helping provide connectivity directly back to facilitate, visits out there, information collection, deployment, and as we move forward into IOC, they'll be enabling the IOC.
All right, thank you. Mr. Dalton, as the prime contractor, Cerner is responsible for overseeing, I think, at least 24 subcontractors. So I'd like to just get a basic understanding of which vendors are responsible for certain aspects of the implementation. So specifically, who has the ultimate responsibility for training?
Thank you. I guess I would start by saying I think we are ultimately responsible for everything that happens. We purpose-built the team based on experience with VA, gaps or needs. It's an ongoing process, so I think we'll continue to evaluate. You may be aware, but last week we held an industry day with over 400 companies in attendance, so we'll continue to evaluate the best capabilities. As it relates to training, Cerner is going to be doing the vast majority of the training for the VA.
Okay, what about testing?
Again, it's a joint team. It's our team, and then we've got a small business contractor we're working closely with.
Who is that?
Has experience, MicroHealth.
And then what about hardware deployment and configuration?
The majority of that, if not most of it, will be done by Cerner, but we work closely with Leidos in technical areas. Accenture is also on the team, helping us with technology and interfaces as well.
So you say it's pretty much a 30-30 jointly responsible?
Generally
for
speaking,
Cerner?
I would say we have the majority of the responsibility right now.
At the elbow support during go live?
Will be a combination of Cerner and a number of other small business partners, most likely.
Can we get the names of who those are?
Yeah, can I provide them post? I don't have them.
All right, thanks.
Thank you.
I understand, yeah. And then finally, help desk support.
That would be done by Cerner Corporation. We'll also, again, work closely with our partners from Leidos on help desk and sustainment.
Great. Finally, just, Leidos, you were the main contractor for DOD. Now you're a subcontractor. I'm trying to get an essence for how the relationships work. And so given these different contractual relationships that exist between each of you as the prime vendor and the constraints that those different relationships impose, how are you communicating with each other and really identifying lessons learned from the challenges? How does the day-to-day communication work?
Yeah, thank you. Well, first of all, I would lead by saying that in many ways we have a boundaryless conversation that goes on. So in a day-to-day interaction, we're not actually reflecting on our respective work shares in a contract or things that we're that are written down on paper, but rather we are mission-oriented and trying to solve problems. So that would be just the ethos of the team. Secondly, we are in operating rhythms, daily, weekly, monthly operating rhythms, where we're sitting next to one another with very defined lessons learned and action plans going forward, and that is a team effort. And not only us, but also with our customer, the DoD, in the DIMSUM program, and I would assume also Travis does the same thing with the VA. And then we're in joint DoD and VA meetings occasionally as well. So, to summarize that, operating rhythms are strong and vibrant, and the ethos of the team is very mission-oriented.
Great, thank you. I am finished with my questioning. I'd now like to recognize Ranking Member Banks for 5 minutes.
Thank you, Madam Chair. Look, this is a huge investment. A lot of money is getting invested in this contract. And while there's a lot of confusing terminology that gets thrown around in hearings like this, I always think it's important that we get to the bottom line. What are our veterans going to get out of this at the end of the day? So my first question is for you, Mr. Dalton. Can you guarantee me that if completed, EHRM and MHS Genesis will produce a single longitudinal medical record?
I don't make too many guarantees in life, but that is ultimately certainly our goal, sir. Yes.
Okay. Mr. Dalton, does that mean that each person, as he or she moves from enlistment to active duty to reserve to veteran status, will exist in the system as a single record, and that will be the same record for both DoD and VA?
Yes. Longitudinally, yes.
Okay. Mr. Walton, I want to throw this over to you. A true single health record means the patient has a single patient locator number in the system. Is each person going to have a single patient locator record number in DoD and VA?
Yes, sir, they will.
Okay. Mr. Waltman, after some debate last year, VA and DoD decided to pursue a single common system, a single common Cerner instance. The overwhelming majority opinion was that that was the right thing to do. So I have a couple of more questions for you. First, this has been characterized as interoperability, but isn't it more appropriate to describe what VA and DoD are doing as pursuing or making interoperability unnecessary in terms of assessing each other's records?
Thank you for that question. So I think that there's multiple parts to that. So having a single record shared between two departments will certainly facilitate certain aspects of operations between them and for veterans. However, there are many, many other sites of care where both service members and veterans will receive care, and all that must be integrated into becoming part of the veteran or service member's health record. So interoperability between the departments and other entities of care remains critical.
So stick with that for a moment. What is the practical difference between interoperability and the single common instance?
So I think the practical differences arise in how the information is integrated to become meaningful to whoever is looking at it at the point of care. The information between the DoD and the VA will be simpler to integrate because it will be starting from the same basis and the same framework. It will be in the same database in many instances. However, for legacy information outside those two systems of care, that has to also be commonly integrated, and that's part of interoperability.
Okay, Mr. Waltman, another question. No one has ever fully explained what would have happened if the departments decided to go the other route, to each install the Cerner EHR, but to do so separately. What would have been lost under that scenario? And does it indicate some limitations in Cerner's ability to interoperate with itself if the EHRs are not identical?
So the evolution of the EHR in general is such that all EHRs have some differences, and instantiations or deployments of EHRs, even the same EHR, have some differences. By implementing both departments in the same common system, we eliminate the risk of many baseline decisions being different. We, as Mr. Dalton indicated, we have the DoD system to work from as the baseline, and so that creates instant commonality between the departments that far exceeds what would be done if all of the decisioning were made independently and separately for two different instances of the system.
So if VA and DoD had separate Cerner instances, how would that differ from what exists now with the Joint Legacy Viewer?
That would be different in that the Joint Legacy Viewer is, of course, read-only, and each department can see the records of their department and the other department, but and community providers in a read-only context. Two implementations of Cerner would be actually somewhat similar to that, in which providers in each department would be able to see into or see information from the other systems, but not be able to interact and write with it. In this case, both departments will have providers who are able to interact and write to and read from the same record. So that is a big difference between how it would be with two instances.
Thank you. My time has expired.
Thank you. I now recognize Ms. Brownlee for 5 minutes.
Thank you, Madam Chair. Just to follow up on interoperability, or maybe not interoperability, but what does it really mean with the community care providers, not just between VA and DoD, but community care providers?
Yes, ma'am. Thank you. So the interoperability between community care providers and either department will be provided via networks of health information exchange. So of course, once we have implemented our health information exchange, the Cerner Health Information Exchange for both departments, which is underway as we speak, then the departments will have access to literally hundreds and hundreds of care provider organizations, as well as tens of thousands, 10,000 at least, providers of care. And that will be through the set of networks and health information exchanges, which Commonwealth provides access to, Care Quality from the Sequoia Project provides access to, and the eHealth Exchange, which VA is already a member of and has access to many care providers. So the network will greatly expand, and the ability to exchange that information effectively at scale will be provided by our health information exchange.
So that capability then is already in the marketplace? Is that what you're saying, in terms of different systems talking to each other?
Absolutely. It has just not been implemented in the integrated extent that we will be able to have the leverage to do from VA and DoD.
One of the other issues that was raised in terms of timeline and meeting timelines is that the VA doesn't have the right equipment, doesn't have the right computers. In some cases, the Wi-Fi network the band is not large enough to handle the data. And this is at large quantities, at large scale. Is that something the VA is committed to getting done? And if they don't, does that slow things down?
Well, so we certainly have the understanding that VA is entirely committed to doing what's necessary in those terms. We have not seen all the specific plans in that regard. I know that, for example, in our site assessments, we've provided recommendations for what they should have and what would be necessary to operate the system, including the provider equipment, including forward deployed hardware that we would need to provide, as well as bandwidth and circuits. And our belief and understanding is that they are diligently working on all of those things.
So you've made it clear to the VA what you need in order to, proceed on this. But and I understand that you're having constant communication with them, but they haven't given you an affirmative that they're, in procurement, they're in the process of receiving this equipment and it will be in place by X period of time?
Yeah, there are certainly things that we are aware of them doing. For example, I know that they have been working on circuits for system bandwidth and things like that. And I know that they are working on, other aspects of the infrastructure required. But the details of that, we would have to defer to VA.
Do you think the VA at this particular point in time has the correct amount of staff focused on this to be able to complete their tasks?
Yeah, I think obviously it's a resource intensive. I think they're working closely with Booz Allen in surge support and otherwise. I haven't seen an instance where their lack of staff has hindered our progress at this time.
Thank you. I yield back, Madam Chair.
Thank you. I now recognize Mr. Roy for 5 minutes.
I thank the chair and the ranking member. I think y'all's indulgence have a competing hearing of which I'm the ranking member, so had to sprint from Rayburn to here. So apologize for missing your opening statements. I'd like to have heard those. And I hope nothing I'm going to ask is going to be duplicative. But I was kind of gearing up for the hearing and listening and looking at what y'all were going to be talking about. I had just a few questions. And I'll start with you, Mr. Dalton, if you don't mind. Obviously the Mission Act allows the VA to disclose veterans' medical records to their community care providers unless the veterans opt out, right? I think I understand that correctly. And this replaces the previous law that required the veteran to opt in before anything could be shared because community care was not designated as a bona fide reason to be sharing records. How is Cerner planning for this new authority to be used in the EHR?
Yeah, I think from our perspective, our goal is to be open and interoperable at all times. One of the reasons to do this is the modern capability and technology, data liquidity, the ability to flow data in and out. Regardless of where anyone's seen, our goal would be that the data is all available in the right location for the provider to make the right decision. That's been our goal since the beginning, and that's how I would expect us to interact in that capacity.
I can certainly say from the conversations with, and I represent Texas 21, which has a significant veteran population, as you know, outside of San Antonio. And this would be maybe, I think, the issue I hear most about when I'm hearing and listening to veterans about what's impacting them and their ability to actually use choice/mission, being able to get out. And this is a significant barrier to that. And I guess as you guys are doing the market assessments and so forth, what do you see that you might need to change or adjust in this framework?
It'll be important that the community providers are participating in this effort. Our belief is that this will actually drive interoperability across the country, that those in the community will want to make sure that they're interoperating through the HIE with the VA. So we believe that this could be a significant driver for interoperability.
Get yourself some water. Might be a
Tough day.
Probably there's a Marco Rubio in there somewhere. Probably.
Heard about that earlier.
With all due respect to my friend Senator Marco Rubio. Another question is a little more technical in nature. Sorry, this is back to you again, Mr. Dalton. But quick question about the software costs. The most recent report VA has provided us indicates a total of $494.5 million has been obligated on Cerner's contracts. How much of that represents software licenses, and how much of that represents work or other work beyond the licenses? Do you know?
I'll have to provide that, sir, post.
Okay, that's fine. Has VA purchased and paid for all the Cerner software that will be used in this project?
No, they haven't. They're paying as they go.
Okay.
So as it's put into use, it's being paid for.
Okay.
Procured.
And what software has VA not yet purchased or paid for? Do you know?
They pay for it by facility
Okay.
versus by solution.
Okay. And how much is the VA obligated and paid out for software so far? Do you know, or is that a number to get back?
I'll also have to get back to you, sir.
Okay.
Apologize.
There's a question in maybe if I may, a question for Leidos, broadly. You spoke about achieving health outcomes to enable military readiness, which is very important, obviously, to protecting our country. How can that focus on military readiness transfer to the VA? What is the DoD doing right that the VA can learn from?
Well, I think there are many things being done right. The ultimate objective of the system is to move the medical records to a modern, commercial, off-the-shelf, continually upgraded system. And I think when we do that, we achieve outcomes like you are starting to see in the Pacific Northwest as it relates to number of clinical appointments, the increase in, detecting, prescription errors or, other safety events, as well as prescription fill rates, things like that. And those will translate to improved health, improved readiness, and lessons learned for the VA.
Okay. So one last question. I think my time's winding up. This would be maybe for you, Mr. Crow. Some questions about the role y'all are playing in. But first, can you elaborate on what you believe the value add is of having a program management office? Can you just walk through that, and then I'll leave it at that.
Sure, thank you. First of all, it's a best practice in commercial and government on any kind of major rollout of an ERP, particularly an electronic health record. So it's consistent with best practices. What we have been providing for the VA is surge support in a variety of different areas, ranging from electronic health record, technical engineering. It's pretty evenly spread across the 3 pillars that we support, from program control, chief medical officer, as well as the technical integration office. And it's a range of functions, from analysis, data collection, aggregation, preparing and maintaining artifacts, and supporting the VA in their role of oversight.
Thank you.
Thank you. I now have a few questions about expectations. So many times when the VA has implemented changes to its information technology and different changes, I feel like a lot of the potential failure is because of unrealistic expectations about what will happen when these changes are made. And I want to just set some clarity around the expectations of what the Cerner Millennium will achieve. There's been talks about veterans having to lug around 30 years worth of paper records, and that will no longer be the case when the Cerner product is implemented. Isn't it true that some records, however, will not be migrated or not be available in the Millennium?
I'm going to pass that to Ms. Stoner.
Thank you, ma'am. There will be some records, particularly on the DoD side, just due to a different data migration strategy, that will not be moved over to Cerner Millennium. Thanks to the acquisition approach from the DoD, and therefore the DNF allowed us to take a different data migration strategy with the VA, because of our Healthy Intent platform was part of the plan from the beginning. So all VA records will be within the Cerner Millennium. As DoD rolls out, all of those will also fall in line. Within Cerner Millennium and within the physician's workflow, there is the ability to access the Joint Legacy Viewer, and that will remain there forever. Part of that is part of our training and change management activities, is to make sure that clinicians understand where they can see all of that information, whether it's from legacy systems, a different location that has not yet transitioned over to Cerner Millennium, or from the community providers.
So let me clarify. The VA has selected 30 data domains, and the DoD has chosen 5. Is that correct? So there's like 25 data domains that are different or not, that you're just going to be able to view in the legacy viewer?
Correct, on the DoD side. So problems, allergies, medications, procedure history, and immunization history will be available for all patients that have been seen in MHS Genesis.
And then what's the length of time represented in that?
On the DoD side, it's all information, because an allergy is an allergy forever, similar with your immunization history, things like that. On the VA side, it would encompass that 30 years of history as we complete that data migration.
Okay. How does this compare with best practices in the commercial sector?
So the DoD was similar to what we do commercially. I think this represents some of the innovation that we're able to do with the VA, kind of exploring this new data migration strategy that would allow for more robust data from the beginning. I think it's an opportunity that, as we prove that out and I'll integrate all of that information over, it may change the way we go commercially.
Okay. Let me see. Explain how this difference will affect the interoperability eventually.
So in terms of interoperability between the departments, all of that information will be available to all users within the system. So if a DoD patient has been active duty, changes to veteran status, and is now being seen within a VA, they will be, all of their active duty information, with the exception of some sensitive data, things like that, all of that information will be able to be seen by future providers because it will all be inherent in the system. Obviously, as time goes, historical data becomes less and less relevant in the clinical record, so all of that information from day forward will be native in the record.
Okay, thank you. Finally, one question I have about infrastructure, and sort of at what point, we know that there are incredible infrastructure needs, that the VA decision-making structure around infrastructure makes it, I'm just going to say, difficult for Cerner to basically proceed. And there's certainly kinks in the system in terms of when this infrastructure will be purchased, when it will be implemented, even to the extent of planning on what exactly is needed. At what point do we get alerted that the rollout of infrastructure on behalf of the VA is going to affect your rollout date? Like, at what point, what's the time lapse that you say to us, hey, this is a problem, we're not going to make our deadline?
Yes, ma'am. So I think that the critical aspect there is that at the time that we have to have capability ready to be tested in the environments and to ensure that those capabilities are ready to meet the training requirements and so forth for go live at the sites, that's the drop dead date for the capability to be there. I think that we would have a pretty good idea of if that looks realistic or not, several months before that. So I think that time frame is not too far from now.
Okay, so we'll know in a couple months if we're ready for you to, or if the VA is ready for implementation.
Or on track.
On track, okay. I'm sorry, I'm beyond my time, and I'll recognize Ranking Member Banks for 5 minutes.
Thank you, Madam Chair, but you get to have all the time that you want. So, Mr. Waltman, let's pick up where we left off a moment ago. Congress gave the departments an interoperability mandate in 2014. They certified that they met it in 2016 based on the Joint Legacy Viewer. I believe you still worked for VA at that time. Either GLV achieved interoperability and solved the problem and the Cerner implementation is unnecessary, or GLV did not really solve the problem. Both things can't be true. Which one is it?
I think that, sir, as we've talked about, there's a continuous evolution of capability in health information technology. At the time that the requirements were given to the departments for what needed to happen in regard to interoperability, the expectation was to be able to see the entire record from each department in one place. That capability was provided in JLV, as I and Chris Miller testified at that time. Since then, the departments have decided, and it's been required, that they have a system in which they can provide care together in the same system. That's beyond the capabilities of JLV. So for the requirements that existed at the time, I think that has evolved, and the expectations and desires for how to provide seamless care, which is the requirement now, requires a health record system that both departments can use together and write into and operate from the same system.
All right, so this will be my last question on the single versus separate instances debate. And for this question is for Cerner as well. You have established that the single instance is going to be more effective in the long run, and I believe you. But what's the downside? Why was there such a heated, months-long discussion last year when Genevieve Morris was running EHRM about what VA was giving up in the single instance?
I think, sir, that's a great question, and there were lots of important discussions that had to take place for both departments to understand what the extent of configurability would be to meet their differing needs to an extent. Not every process or every workflow is identical between the departments. However, I think what folks realized is that much of the differences between the departments are external even to the EHR. And so in terms of both departments understanding that we're starting with a commercial baseline and there's a configuration band, as Mr. Wyndham likes to refer to it, in which the system can support variability between workflows and requirements of the departments and do so successfully in one system. That took a while for people to explore and understand.
All right, well, I find it hard to believe that VA isn't losing any autonomy in the single common system. In other words, that VA can have their cake and eat it too. What do you say to that?
I think that autonomy and operation capability, I think I would describe it as this. There are certain decisions that were made in the DoD baseline. From the last workshop, for example, I was in a meeting where they were discussing what went into a drop-down for selections in a prosthetics workflow. There were already decisions made there, and the discussion was around, do those words work for VA as well? Those are kinds of things where VA would have just decided what they needed otherwise. However, so they may be giving up having to adapt to a few of those kinds of decisions or figure out how to integrate and work with it, but the benefits far outweigh the challenges in doing that, I think, in our view, given that the seamless care providers will be able to provide for veterans and service members on both sides far exceeds the limitations imposed by some of those word choices and other things in the system.
All right, Mr. Dalton, Cerner's Health E-Intent software is a popular health system. Can you explain how Health E-Intent is different from the core EHR Millennium?
Healthy Intent is a product we use to aggregate data from multiple data sources. Millennium is the core EHR, so Healthy Intent is a platform that coexists with Millennium, and we use it to ingest, integrate, normalize, and move data into the MR.
Okay, that's all I got. Thank you very much. I yield back.
Thank you. I now recognize Ms. Brownlee for you're done. Okay. I just have a couple more questions I wanted to ask. The VA has said some functionalities are not available in Cerner's commercial modules, including nutrition, long-term care, invasive cardiology, and prosthetics. For each of those modules, what is Cerner's approach to assessing how it can improve or acquire those functionalities to meet VA's needs?
We're working closely with the agency, obviously. They have unique needs based on their patient population. I'm going to kick it over to Julie to go a little further.
Yep. So a lot of this process gets identified during what we call our current state assessments or current state reviews, where we have teams on site and can understand some of the niche workflows, things that are different than what we see commercially. For example, the nutrition care or example that you provided, that was identified pretty early on, and then we've been working with the agency to determine what is the best path forward. Whether it's integrating with a new solution that we work with, if it's integrating with something they use at one of their existing facilities, so that we can still provide that service to them, just in this case through integration rather than native into the EHR.
How are you using this workshop process to balance like what VA's expectations are versus potentially a push to meet what's available in the commercial market?
Through our iterative approach, we've had the 8 national, we'll have 8 national workshops as well as the local workshops. A large part of those workshops is change management and training of what is the capability, how does that work into their workflow. One of the biggest things in this space is standardizing an organization that has been independent for so long with the 130 different instances of Vista. Each area has been allowed to do things a little bit differently. So I'd say the biggest challenge has been what does standard in the VA look like, and how can we integrate that into the EHR? And then through the iterative process, we're allowed to make a decision, we can configure it, and then in the next workshop provide that back to them to review and react to, sometimes that may mean we have to reverse a previous decision because it sounded like a good idea, but now that they saw it in reality, like, that doesn't quite jive with what we want to do. And that's why we have so many workshops, is to allow that ready feedback so that we don't get to the end and go live and find out that it doesn't really meet the
Didn't work,
needs.
yeah. Thank you. Do you have any? You good? Okay. Well, I think this is the end of the questioning, and I'd like to thank all of you for this very helpful discussion. We all look forward when we have our next hearing on EHRM on June 12th, and I'd like to thank all of you for your attendance and hope we can work together and obviously have the transparency and the notification that's needed to make sure that we remain on track and obviously produce a successful product that delivers health care to our veterans and our service members in a seamless manner. So thank you very much. All members will have 5 legislative days to revise and extend their remarks and include extraneous materials, and the hearing is now adjourned. Thank you.